So I did want to be really brief, and I'm going to be even less coherent than usual because I was in India yesterday and I'm a little out of it. But it's a great opportunity to talk with you a little bit about, less about the Global Fund per se, and more about the amazing opportunity we have in the world today around HIV, TB, and malaria, and more importantly, what that means for us as human beings. A little bit about innovation, and then just have a conversation, I hope. And hopefully you're all more awake than I am. So AIDS, TB, and malaria. So these are pretty amazing diseases in some ways. For those of you who don't know, and probably most of you do, TB and malaria have been around since recorded medical history, literally thousands of years. You can go back as far as you want, and you'll find evidence of malaria or tuberculosis. And they've been hugely impactful in human history. And HIV is kind of the modern, not kind of, it is the modern day plague. It's the disease that's really had a massive social impact in the world today, really since 1980. Now, a lot of you may have been born and don't even remember a world without HIV, but some of us do, and it's really a radically different place. I happen to be in San Francisco during the worst time when, for those of you who go to San Francisco now, to go to your mothership, it's hard to describe how different a place it was. I mean, it was actually a depressing city where you didn't even want to be because everyone was dying all the time and life revolved around funerals. I mean, it was actually a terrible place to be. But because of advances in science, because of massive investments, started really by the United States under President Bush, but then taken up globally, because of the leadership we're seeing in the countries themselves. We actually are on the verge of and have the capability to do something that seemed impossible 15 years ago, which is actually end them as epidemics. Remove malaria and tuberculosis from the planet, which, again, it's been around for thousands of years. And while we can't eliminate in the same way HIV yet, we can bring it down to such low levels that people wouldn't even have to talk about it anymore. What we call epidemiological control. There's a really fancy term for it I won't tell you about, but low-level endemicity. And then when we get a partially effective vaccine, that would be it. So that's really cool, right? I mean, these are things we actually can end. It takes a lot of work, takes a lot of effort, and takes a lot of focus, but we can actually do it. And this is the first generation that's had that capacity. I mean, this is the first generation in thousands of years that's had the ability to end tuberculosis and malaria. And this is the first time we've had the ability to end HIV. When everything started about 15 years ago around HIV, it really was stopping the death. It was just trying to stop the hemorrhage and the death and the depression that was around cities like San Francisco and certainly in Africa. It was ending the hopelessness. It's impossible to describe how hopeless people felt. If you went to a village in Africa, literally no one talked about education or health or bringing up their kids. They all thought they were going to die. And it was a pretty good bet, actually, just 15 years ago. Just 15 years ago. 15 years later, we can actually see the end of these epidemics. But what's in some ways even more exciting than that is what that would mean for us as a human race and as people. So, you know, most infections are pretty indiscriminate, whether it's the absolute hysteria about Zika, which is totally unfounded in anything scientific, or Ebola or influenza. If you come into contact with it, in fact, all of you probably over the last couple of months get sick fairly regularly because you come to work and touch doorknobs and shake each other's hands and you get sick. And it doesn't matter if you're rich or poor or what color you are or if you're gay or straight. If you come into contact with a infectious disease or an infectious element, you have a pretty good chance of getting infected. HIV and TB are very different diseases. They're actually diseases of the most marginalized and vulnerable in society. TB is fundamentally today a disease of the poor, of the poorest of the poor in inner cities, living together in close quarters with no access to medical care. Or it's linked to HIV, because for those of you who don't know, HIV per se doesn't kill you. HIV destroys your immune system, so you die from other things, and actually TB is the main thing people die from. So TB and HIV are very closely related. And the people who are at most risk of HIV are, again, the most vulnerable and marginalized in society. So it's the LGBTI community, particularly gay and transgender, and the numbers are frightening. I mean, if you go to Latin America, Asia, where the epidemic's largely controlled, 30, 40, 50% of trans and MSM are HIV positive. It's related to sex work. Sex workers are very highly at risk. People who inject drugs, prisoners, and migratory populations. That's who's at risk of tuberculosis and HIV. So unlike most infectious diseases that are indiscriminate, these diseases are incredibly discriminatory. In fact, they prey on discrimination, and they prey on the most marginalized and vulnerable who don't have access to services, who are left behind by society. And so to end the HIV and tuberculosis epidemics, we actually have to become better people. Which is not actually the case with most infectious diseases. We have to create an inclusive human family where everyone is welcome, where everyone has access to health care, where discrimination and stigma no longer prevent people from accessing their basic human rights and access to health care. And that's pretty extraordinary. I mean, when you can end these epidemics that have been around for millennia and the modern plague, but the only way you can do it is by creating a society we want to have for the world, that's really cool. And that's pretty rare when you can pull these two things together. And I think that's one of the reasons we're so excited about the current opportunity in where we are today. And it's hugely exciting. But it's also a little frightening because the world's a pretty scary place in some ways right now. But it's also a world that's filled with opportunity. I was just in India, I mentioned. I met with a group of about 40 NGOs, mostly sex work, trans, and MSM programs. They were crowded in a room about this size. If we tried to have that same meeting 15 years ago, we basically would have been meeting with in a closet with two people and whispering because no one would have wanted to know who we were. And while they were complaining, and appropriately, that they don't have the access that they want, that there's still discrimination, just the fact that they were there was extraordinary. You see the same thing in Nigeria, and Haiti, in places, Kenya, no matter where I go in Asia. When I first went to China and Vietnam, the part of the Department of Health that dealt with the gay population, the transgender population, and the people who inject drugs was known as the Department of Social Evils. Now it's part of the Ministry of Health, and I go to gay MSM trans programs with the Minister of Health. It's really changed. It's changed tremendously, and it's changing in a stepwise kind of genetic leap way, not a slow progressive way, but a genetic leap way. And I want to talk a little bit about that genetic leap way, and one of the groups we don't talk enough about, and it's astounding to me the number of people who are actually involved in HIV, including in Africa, who don't understand this. But the key affected population, or the key population most at risk for HIV today, is not the traditional populations. It's actually young women, adolescent girls and young women. The rates are astronomical. The rates are 5 times higher than in boys, adolescent boys and young men. And it's largely driven by transgenerational sex, but it's largely driven by the fact that women aren't counted as part of society. Adolescent girls aren't counted as an equal part of society. And so gender-based violence is rampant. Abuse is rampant. Somewhere in the neighborhood of 40 to 60% of girls will have their first sexual encounter through forced or abuse in parts of Southern Africa. When a girl is born, she's not even registered, so we don't even know how many. That's how little they count in society. It's total gender inequality that's driving the HIV epidemic in Southern Africa. And so we actually can't tackle and end the epidemic unless we get a hold of gender inequality. And that's one of the areas that don't often come up, particularly in the United States, where it was largely a gay-driven epidemic, still kind of is. But when you get outside, it actually is very much, in Southern Africa is where the epidemic is most out of control, or least in control, and it is heavily, heavily driven by gender inequality. And so we can't end the epidemic without not only dealing with the traditional populations that are left behind, but by a population that's half the world that we don't even often think of as a vulnerable population, but it's adolescent girls and young women. And what's particularly frightening is because the birth rate is so high, the number of girls, women, and boys actually who are 15 to 24, which is the most at-risk group for HIV because it's the most sexually active, is going to double. That means that even if we reduce the rate of HIV by 50% in this population, we'd still have a growing epidemic. And we've never reduced the rate by 50% in a group like this. So it's a really frightening demographic picture, and it really tells us how important dealing with fundamental structural equality issues are for ending an infectious disease. Now that youth bulge also has a huge opportunity because normally it takes a generation or generations to change issues of human rights and equity. But when it's a lot of young people, that's going to be 60% of the population, you can actually change much faster because if that generation changes your view, within 10 years, you're actually the majority of the population, rather than waiting for slow change, waiting for what the Romans used to call hope and death, waiting for people to die off so things could change. It can actually change radically. And it can change radically even where you don't have that because of the work you all do, because of the ability of people to connect in a way that we weren't able to do not long ago. And so social movements can lead us from where we were 10 years ago in gay rights in this country to where we are today like that. And that's something that's a pretty remarkable thing in social dynamics and pretty remarkable thing lately. Instead of going multiple generations of women fighting for the right to vote over 50 years, you can change things in 5 years. And that's the huge opportunity today to end the epidemic, end these epidemics, but to do it by becoming the inclusive human family we want to be, and by thinking about how we use mechanisms that we use to sell things, to talk to each other, to connect to each other, to actually change who we are and change our society. And that type of innovation, I'm sorry to say, global public health or public health is not particularly good at. In fact, we're awful at it. You'll still see billboards, for anti-HIV campaigns. I don't know last time someone actually looked at a billboard. We still do ads in papers and just nonsense stuff. No one's actually tapped into the social. They still go to bars to pass out condoms. People don't meet in bars anymore for the most part. For sexual encounters, there are other ways to do it. And no one's reached into this world yet. No one has reached into this world yet. There are a couple of efforts to kind of eke our way in. And then think not only about how you would do it here, but how would you do it in Africa? How would you reach young people in Africa? Well, all of them have cell phones. All of them are online. All of them are talking to each other. They're not listening to their tribal leaders anymore. They're connecting to the world. So how do we connect and create a social movement that will actually drive these changes that are essential for us to end the epidemics, but we can't do it without changing who we are. And that's really cool. That's fundamentally different than, say, Ebola, right? You didn't need a social movement to end Ebola. You just needed to contain it. To end these epidemics, we actually need a social movement and social change and a radical shift in human rights. And that's, I think, one of the most exciting things and why a lot of us get so energized about the potential, because it's not just an infection. It's actually an infection of society. It's an infection of our values. And there's a correction to that infection. And it's not going to come from a pill. So it's great to be here because you're all the ones who can help us figure out how to do all that. I'd be happy to talk about anything you want to talk about, but thanks for taking your time, and thanks for your interest in these diseases, because to be honest, there's not a lot of interest in them anymore. We're losing it pretty quickly, and if you guys don't engage, if your generation doesn't engage, we will lose the opportunity down these epidemics, and the next generation and the next generation will still be dealing with them because we didn't. So I hope you join us and figure out how to do it. So I'd be happy to take any questions.
Hello. Yeah, thanks for being here. Actually, it's cool to see you. Yeah, I just wondered.
Maybe your name would be helpful, or.
Oh yeah, my name is Christian, software engineer. So I'm not very, only by secondary like interest. I'm interested in these things. So yeah, I wonder. Yeah, it's amazing for me that you see it as a social problem and actually change society. Do you know about, like, especially like sub-Sahara Africa, about some social experiments that have been conducted, like, but there's some countries that are like have really succeeded in doing this, and some experiments that have not succeeded very well? Like, basically, how do we solve it?
We actually don't have experiments per se. I mean, it's really hard. We have a lot of experiments on drugs. So, you know, if you give a drug, we know which drugs to use, we know how to use them. But then we don't know how to get people to actually take them every day, which is a behavioral thing. It's part of social change too, right? So that's why we have these massive drug resistance profiles, because people aren't taking them. But we do have behavioral studies around adherence and how to increase adherence, so that we're getting pretty good at. In terms of how you actually change sexual behavior or societal behavior, we have nothing in the way of good studies. And the reason is it's really hard to control for things. You can't really do randomized controlled trials. You know, there are no good randomized controlled trials on how to stop smoking. You know, they moved past that. The only thing that's ever been proven to reduce smoking is laws and taxes. So there are actually no data, because it's really tough to do the randomized controlled trial, on all the social change that has happened over the last 30 years to basically stigmatize smoking, all the campaigns. None of that has ever been proven to make any difference whatsoever, because it's impossible to do that study. So that comes to the art of public health, you know, using common sense and trying to figure out what works and what doesn't, and basically throw as much as you can at the wall and see if it sticks. So there are sadly, there are almost no places where we've seen reductions in, say, adolescent girls and young women. And it's actually hard to study. It's really hard to study the rates. What we have found recently, and this is pretty exciting to us because it links education and health, is that if you can keep girls in school, secondary school, the rates of HIV can drop dramatically. Because if you're out of school, your risk is really high. And the reason is you engage in transactional sex for things like cell phone money, or families actually tell their girls to go, functionally they tell their girls to go have sex to bring some money home. And so if we can keep the girls in school, what a study in Botswana showed is for every year a girl stays in secondary school, the risk of HIV drops by 12%. Which is pretty remarkable, right? And over time, it was actually 65% in a study in Malawi for the girls who stayed in school. And the way we were able to keep them in school was by giving them a very small cash incentive. And either giving it to the family so they didn't try to sell her off, or giving it directly to the girl so she didn't have to sell herself in a transactional way. And often it's for cell phone time, or it's for school fees so that they could go to school, or for a uniform so they could go to school. So that's one insight. So now I'm going to Swaziland tomorrow, Sunday, they're actually launching a program to do this because they have a really high rate in adolescent girls and young women. And then we're also doing gender-based violence programs, but we don't have really good studies. So what we're doing now is saying, you know, we're all a bunch of scientists. We're never going to have a randomized controlled trial that proves this. What we have to do is just do a bunch of stuff that makes sense, that there's links to, and then study the rates and see what happens. And don't worry about whether or not we can say this or that specific intervention did it. Let's just do 5 interventions that seem to make sense and see if the rates come down. And that's what we're starting to do now. The US government, through PEPFAR, we're supporting this program. PEPFAR is something that's been a great bipartisan program. It's really one of the things the United States should be most proud of, really. Largest international health initiative in history for a single disease. No one was putting any money in global HIV before this. Now the US is by far the leader. They have a program that we're very linked to. We work really well in country. But it's a great question. We don't know. And part of the reason we don't know is because we have too many white, male, older doctors involved and scientists involved in all this, you know, who keep doing the same thing over and over and over again. We actually need people who would say, well, if you did this, this would be a way to reach people, or have you thought about that, or can you do a game, or can you do how would you link young people? How would you talk with young people online to get them to behave, you know, understand their risks and even learn what their risks are? So that's what we're trying to do, get people interested in this, which they really haven't been, and move the scientists off to the side. We're great on the pills, we're great on the medicine, we're not so good on social problems. And so the bottom line answer is we don't have the data we would like to have. We don't even know how to create the data we would like to have. So we'd love to have anyone engaged who wants to be.
Yeah, sounds like it would be cool to like get psychologists involved.
Anthropologists.
Yeah, yeah.
We actually have, but there are also a bunch of doctors. So, and older. So
Bigger
you know,
as well, isn't it?
yeah. We do. There are a lot. There are more and more, but you know, really, these people are moving away from these diseases. You know, just at the moment, we're on the cusp of. Really, we're on the right side of the tipping point right now. We could get on the wrong side really quickly. Everyone always, you know, everyone talks about a tipping point and thinks they're going. You know, tipping points have two places you can tip, right? You can go in the right direction or the wrong direction. We're on the right side of it now, but we could easily go the other way. And we are losing the people who used to be energized and interested and literally go to these meetings, except if you're in India and Africa, and it's the same people who were doing it 25 years ago. So I don't know, psychologists help. I'd rather have social media people, actually.
Thank you.
Hi, I'm Stefan. I'd like to know what your plan is for malaria, because it's sort of not necessarily a very social targeted disease.
It's a great question. I mean, obviously you all know you can eliminate malaria because you don't have to worry about it, right? So you can actually eliminate this infection. And one of the reasons I was in India is actually getting close. They don't have malaria up in the northeastern border, and they launched their malaria elimination plan. Malaria, unlike say HIV and tuberculosis, is purely a medical disease. It's mosquitoes. It's not a social disease, but it's social to the extent that it's linked to sanitation and water and access to health care, and that's why TB is all over, and it's in India and China. HIV is heavily in Africa, and it's heavily in. Now, there's probably some medical reasons to it we just don't understand. But malaria is one that we can eradicate. The complexity is sticking with it long enough to eradicate. So what we've often done, and actually we've done this before, there was a malaria elimination effort in the 60s. It did pretty well, but we didn't carry it all the way through, unless you really eliminate and eradicate, it comes back. And it comes back really quickly. When the Minister of Health of Zanzibar, which is an island, was told that the president's malaria initiative was going to support them to end malaria, he literally said, "Oh, that's great. We know how to do it. We've done it 3 times," and they actually had. But mosquitoes keep coming back. They come on a ship, they come on a plane, they keep coming back. So what you have to do is have a really smart plan that pushes to elimination, but it has a regional approach, and that's always been complicated because mosquitoes don't really don't follow geopolitical borders, and so they fly all over the place, and we actually know how far they can fly now, and we're being much more strategic about cross-border stuff. But to some extent, it's the same thing with HIV and TB. And it's actually happened with smallpox. If any of you care about this, read Bill Foegge's book, House on Fire. It's 100 pages. It's a really cool book. And it's about how smallpox ended. And only a fraction of it is about science. It's actually mostly about how you change people's mindset. And the biggest mindset change was moving towards trying to control it, to end it. Because what you try to do when you control an infection like malaria is very different than when you try to eliminate it. So we're really trying to shift everyone's thinking from it's not control, it's not reducing the rates, it's actually eliminating and sticking with it until you eliminate. So we're very excited that in the last literally 2 years there's been a big shift, and Bill Gates has had a big role in this, towards shifting our mindset to eliminating and moving region by region. So there's now a plan that we think 35 to 45 countries can get to elimination by 2020-25. And then you move the next step, and then you have to maintain the control rate so that you maintain the elimination and it doesn't bounce back, and then you just keep pushing. So we actually now think by 2030 we can eliminate malaria from the planet. I actually think, and Bill thinks, we can probably do it by 2025 if we really focus on with a little more innovation. But then the trick's going to be sticking with it another 10 to 15 years so it doesn't come back. With all the Zika madness around, it's the same thing. or a dengue, it's the same mosquitoes. So vector control, controlling mosquito-borne diseases, actually is more than malaria. It actually would do the same thing for dengue and do the same thing for Zika, which doesn't kill anyone, by the way. I mean, it's really just insanity, the hysteria around Zika. I actually had someone who works in our office in Geneva, in a global health office, asked me if it was safe to travel to the United States because of Zika. I mean, that's how crazy it's gotten, right? But it's an entry point into how you do vector control. There's also a new movement to eradicate mosquitoes, which is probably going a little far, and I'm not sure we can do it. But there actually is an elimination plan, an elimination strategy, an elimination mindset now, and I think we'll get there. I actually think we'll get there. That's the easiest of the three.
You've used the word innovation a few times and kind of pointed out you don't actually know exactly what the steps are to eliminate these diseases. Maybe you can tell us a little bit about how the Global Fund works and maybe with an eye towards how that supports or attracts innovation.
So we're actually a pretty unique institution. I'll digress a little bit because it's Friday afternoon and I'm tired. But so 15 years ago, if you asked anyone, what are we doing in the world to fight AIDS, malnutrition, better agriculture, anything in development really, the answer would have been we're spending X amount of money. I mean, literally, you can go back, that was the answer, we're spending X. There was no link to what are you doing with the money, how's it going. It really was just how much you spent. And there's a reason for that. I mean, development was not born of the most noble, origins. It was a colonial thing to start with, then missionary related to colonial, then Cold War related. And so really, the reason the answer was how much you spend is a lot of development was making yourself feel better. So you were giving money to poor people because you did some really bad things to them historically. Or making them like you. So you were trying to like yourself better, or you were making them like you by giving them money. You didn't care what they did with it as long as they liked you in the Cold War. And that's really, that's not why people did development, but that's where the money came for development. So there's a reason for that answer. Then people started to realize, well, actually, we're giving a lot of our tax money away, and the Cold War is almost over, and we shouldn't be doing that anymore. And then it shifted to, what are you doing with the money? How are we achieving results? How are we partnering with people rather than treating them like children and patting them on the head by giving them some money? And that change happened around 2000, actually. And then there was something called the Millennium Development Goals that were born out of that. And the Global Fund was actually created out of that radically new, I mean, really a genetic shift from 100 years, literally, of thinking and development to how do you partner with people? How do you bring people together? How do you support the countries to achieve their objectives, not my objective in their country? How do we recognize that it's not us with all the ideas that are coming to show these poor people what to do, but to supporting them to create the ideas that will solve the problems? So we were created that way. So we don't have any country presence, unlike almost pretty much any development organization. We're a financial mechanism that brings people with the resources together with the countries that are implementing, including civil society, the private sector, all around. And the idea was that we would use resources to then support countries to achieve their objectives, that they would lead and run and innovate. And so a lot of the innovation that we talk about, now there's scientific innovation. In India, people were using tablets. And literally, community healthcare workers were carrying around backpacks filled with files. Now they carry around a tablet that pushes data to a centralized source, and they're actually improving their efficiency dramatically. That was pretty cool technological advance. There's technological advance with drugs or mosquito bed nets that now have insecticide in them, so they kill the mosquitoes. You don't just keep the mosquito from biting you. There's actually genetic modification of mosquitoes that can actually have a swarm effect that can't transmit malaria. And they're genetically modified so that they dominate, so that you could actually introduce them into a population and get rid of the malaria-carrying mosquitoes. That's really cool scientific innovation. But then there's the innovation on the ground. Like, how do you keep a person coming back take their antiretroviral therapy or their TB therapy. And those innovations are the communities on the ground figuring it out. How to keep girls in school. Those are the communities on the ground. And we've actually gone in and looked at some of this, and it's amazing what they come up with and the solutions that they find. So we were designed basically to provide the resources to stimulate that innovation from a national level down to the individual healthcare worker. Hasn't always worked the way we wanted it to. We're trying to do more and more of it. We've actually created an innovation hub to bring the best ideas together, to stimulate them, to catalyze the change, to be a little more proactive in bringing the lessons learned around as we learn them, but also to be comfortable with, and this is something health people have always had, medical people have always had difficulty, be comfortable with not knowing, be comfortable with playing a little bit, be comfortable with failure, to let this innovation bloom. And that's what we're getting more and more and better at. But it's really cool, the shift in how we've thought about development. Beyond, the mindset hasn't changed. I still hear people talk about, oh, those poor Africans were coming to help. We're not coming, they're actually doing all the work. We're just providing them the support. And it's really remarkable. I've had the privilege to go to the same communities 15 years apart and to see the difference from, the hopelessness, the total despair, to these incredibly bright people who have came up with the best solutions that are solving their own problems, to empower them, including with the technological tools like a tablet, but to empower them to then solve their problems. And that's what the Global Fund was created to do. So we collect money, and then we disperse money. We disperse about $4 billion a year, collect and disperse about $4 billion a year, which makes us the largest multilateral funder of global health of any kind for HIV, TB, and malaria. The US government has a bigger HIV program, we have a bigger malaria program, and a bigger TB program. But you put that all together, and we actually, and the countries now, this is pretty exciting actually, the countries now are spending as much or more of their own money to combat HIV, TB, and malaria is coming from the outside. There's still this perception all the money's coming from outside. They're actually paying 50% of their HIV, about 52%, 48% of their malaria, and about 80% of TB. Because TB is largely, 70% of the TB in the world is in the BRICS countries. So they're the ones mostly paying for it. So what we do in those environments is actually try to catalyze change, innovation. Bring innovation, share innovation, but not in the sense of I have an answer, you have to take it, more in the sense of how do we solve a problem. And that's what the fund was created to do. So it's actually a pretty neat job. We're a Swiss foundation, but we're a multilateral organization that functions like the UN, but we're not of the UN. You're back.
Yes, Christian here again. No, so I wonder a little bit about tuberculosis, like more technical. As I understand, like tuberculosis, you researchers don't really know how it works, kind of. And is there a treatment? Like, if I get it tomorrow, is there a medicine to take for me? And how expensive is it to actually, technically take a pill and be good?
So the fact that you don't know is actually pretty cool, because it means, which is true, most people don't have to worry about tuberculosis. So the only tuberculosis in Switzerland or the United States, or actually almost all of Western Europe, is TB, same for malaria, that gets imported. Someone goes someplace, they get coughed on, they get TB, or they go someplace and get bit by a mosquito and they come back. That's the only case, it's imported, which means you can eliminate it, right? Because it's been eliminated in a lot of places. So TB is in some ways the most frustrating to me because it's we have curative therapy. It takes 6 months to cure tuberculosis. 6 months. HIV is lifelong therapy, right? Could you imagine if we had curative therapy in 6 months for HIV? I mean, we have the activism, we have the galvanism, HIV would be gone. The rate of decline of TB, despite the fact that we have 6-month curative therapy, is 1.5% per year. It's pathetic. By that rate, it'll take 200 years to end TB. And what's even worse is while we have a 1.5% decline in new infections per year, wow. Because of the growth in the population, we actually have more people with TB, even though the rate's slightly going down. So it's enormously frustrating. One of the biggest problems is no one cares about it. because it's mostly poor people in inner cities that governments don't spend a lot of time on. They're people who don't understand that they have access to health care. They literally will be coughing themselves to death before they go to a hospital or before they go to a clinic. And by the time they've done that, they've infected a whole bunch of other people. And then the programs aren't particularly good. And what's equally problematic right now is the public sector. So India has 25% of the TB in the world. You put India and China together, you're almost 45%. Again, the BRICS are 70%. You know, development agencies aren't going to be doing a lot of stuff in BRICS countries. And in Southern Africa, it's largely linked to HIV, as I mentioned. And interestingly, a lot of it's related to migratory miners. It's not their fault. You know, they do one mine in Mozambique. That season ends, and then they go to their home family in another country. And they were on their TB drugs in the mines because they actually test you because you're in a confined area, and you know it's not good to have TB people in your mines. But when they leave, they stop their drugs, and then they go home and cough. And they cough on their family, and then everyone in the community, and the data tell us this, get infected. And then they go to a new mine, and they start a new drug regimen, which is different than the one they took before because the countries aren't aligned in the regimens that you take. And then they go to a new family, because often they have more than one family because they're migratory workers in another country, start the process again, and it keeps going and going. So about a third of all new TB in Southern Africa is from migratory mining, a third of it. And because it crosses borders, we've not followed it at all. We're just starting to do that. So this is not a technical problem. This is actually just a public health approach problem, and it's a willingness to reach people who are migrating, people who are poor in inner cities. This is not a technical problem, this is a social problem. The only technical problem is diagnosis, which isn't particularly easy. Hopefully we'll have a new urine test. And increasingly, you know, we think of TB in the lungs. TB actually can be anywhere. TB actually used to be known as the inscrutable disease. Anything could look like, anything could be TB. And there's more and more TB that's not in the lungs. And that's even harder to diagnose. So the diagnosis part is actually a technically difficult thing. But once you've diagnosed and identified someone, if you take your drugs every day, you're cured in 6 months.
Cool. But why do they stop taking the drug? Is it an educational problem that they don't know that this
When's
is
the
actually
last time you
dangerous?
took, say, an antibiotic?
And
When's the last time you took a drug that required you to take it for 10 days? 15 days?
That was a while ago. But I did it at
Did
least.
you? Yeah.
Yeah.
So there's one of my favorite studies. I used to be an infectious disease doctor before I became a bureaucrat. And one of my favorite studies was among infectious disease doctors who were given a 14-day course of antibiotics because they had an infection. About 30% finished it. These are infectious disease doctors, right? So the natural course for anything is, and I bet most of you have done this, you start taking it. As soon as you feel better, you stop taking it. All right. So, and taking drugs every day for 6 months isn't particularly fun, and it's not easy. And 6 months is a relatively long time. So we started something called directly observed therapy, which actually works, but it got misused because public health bureaucrats got a hold of it, and we created a bureaucracy rather than listening to people and understanding how to do it. And then think about HIV, which is lifelong therapy, right? And the other thing about these especially HIV drugs, is every time you take a pill, it reminds you that you have something. Right? Most people don't want to be reminded that they have an infection. They'd rather think they're healthy. And when you feel healthy, so it's normal. Was it you who said we should get psychologists? You know, it's normal human behavior. And if infectious disease doctors can't even finish a 14-day course of antibiotics, just imagine how complicated this is.
Can't we do some like stick that you operate in? I mean, they're like preventives.
Yeah.
Yeah.
Yeah. No. We're getting more and more to that. So. We don't have them yet for tuberculosis, but people are worried. And part of the problem is there's no market for tuberculosis drugs, right? The tuberculosis is for poor people in poor countries. So why would a company invest in an innovative tuberculosis product that they're never going to make any money on, right? HIV is different because there are enough people in Western markets that they can make money on. Malaria is the same thing.
But you have money.
No, we don't do research. The Gates Foundation and the U.S. National Institutes and other national institutions have actually created partnerships. What we can do is say there'll be a market, right? So if you produce that, we'll buy it. You won't make a huge profit, but really, if you're a drug company executive and you can make Viagra, or you can make an anti-tuberculosis drug, which one do you think your board's going to want you to make? right? So you have to actually stimulate these low profit margin investments, and we've gotten much better at that. And we do have a role as a bulk procurer, but there's not a lot of incentive. But there is really cool stuff. So there are now 2 injectable HIV products that last, we hope, 3 months that are being put together. We're not sure if they'll work for treatment, but they'll work for prevention for sure. For those of you who don't know, there's also something called Depo-Provera, which is an injectable family planning product that we're working to put in with the HIV drug. So imagine we could actually have a drug, 1 injection every 3 months that prevents HIV and is a family planning tool. There actually is a long-lasting subcutaneous family planning device too. The problem is volume. That's the biochemistry. It's the volume and it's the reaction. But we're getting there. But there hasn't been the incentive. It's not actually the science. We could probably figure it out. It's the incentive. And this is where the Gates Foundation and others are investing to create those technologies.
Thanks.
I'm interested in how the problems you're addressing are related to poverty. You mentioned several times how that's entwined, I guess, in different ways. Is that, how closely linked do you see that is, and do you do work with anti-poverty organizations as part of what you're doing?
It's a great question, and really gets to, TB is a disease of poverty. Malaria is in a lot of ways a disease of poverty because it relates to sanitation and water and access and having a living condition. But we can't do everything, and the expertise that's required is completely different. And so we don't actually invest in anti-poverty efforts. We work with organizations like the World Bank, the UN Development Project, and others, and fundamentally with the countries, because economic growth is actually, as long as it's equitable, actually can be great in terms of lifting out of these things. HIV, as you probably well know, is not a disease of the poorest of the poor. It's actually a disease of the slightly more mobile, including in Africa, and those vulnerable populations. So we link with them. But just coming out, this has been one of the myths that's been annoying a lot of people, is we'll just have economic growth and that'll solve all our economic problems, or all our disease problems. Well, that's only true if you equitably distribute the resources, and we're becoming a more and more unequal world. We're actually involved in something called the Equitable Access Initiative, which I'm not going to get into, which is pretty cool, which is trying to address some of these issues through a health lens. But it's a really good point, and it gets to how can you stay within your mandate and still have an impact. So we try to link with and then support countries to have the fiscal space so that they can actually combat these infections at the same time that their economies are growing.
So I'm about to raise a subject that is bound to be a little bit contagious, but one of the measures that have been taken against mosquito-borne diseases such as malaria are insecticides. Mm-hmm. Now, DDT is of course far from a good substance, and it was banned in I think the late 80s, around that time, and it was also made. The developmental aid was also made often dependent on banning the use of DDT. Now, of course, I'm not a chemist. I'm not aware of exactly how justified this scare of DDT was, but by some accounts, actually banning this substance has cost up to a couple of million or tens of millions of innocent lives. Now, so I've got 2 questions for you. How justified was this scare, and is there research into other insecticides that may actually be just as effective as DDT, but less, damaging to other life?
So, and this is still, unfortunately, a debate, but it has changed a lot since then. So WHO has certified DDT as safe. We buy a lot of DDT, and countries use a lot of DDT. Some countries still don't because they, still remember these things. But DDT is now a valid insecticide, and we support countries to buy a lot of it. There are side effects. There's side effects to everything, but used smartly, and the side effects that we used to see, we don't see so much anymore. There are 2nd and 3rd generations insecticides that are as, if not more, effective. The problem with all of them is resistance over time, and we're already starting to see. So there's DDT resistance, then we use this other one. But interestingly, then the mosquitoes that were resistant to DDT die. because they got sprayed with the new one, and then DDT sensitive again. So we actually have to measure periodically, and you rotate insecticides. And then there's a new generation, because we're actually starting to see resistance to all of the insecticides. And we also then put insecticides in the bed net, so it's not just the spray. And because it's pretty cool, you kill the mosquito, you don't just prevent it from biting you, and that has an impact. So what we saw early on is with insecticide-treated nets, if you put nets in a village, the next village actually had a reduction in its malaria rate because the mosquitoes were dying. So because we used the same insecticide, we then started amplifying the insecticide resistance with the bed nets and the sprays. So we do cycle now. The third generation is great, but it's very expensive. It's about 3 times as expensive as the other two. And so we're playing both to reduce the cost, but also on how we rotate in an intelligent way, which gets back to elimination. You actually do need spraying for elimination. There is no silver bullet for anything. So you have to treat, you have to spray, you have to use bed nets, you have to put it all together, and you have to do it in a public health approach. But for the most part, we're past the DDT issue. There are still some countries and still some people who periodically raise it, but it's certified by WHO, and most countries now are comfortable using it.
Too tall. Hi, I'm Daniel. I'm an attorney with some interests in public health law and ethics. You mentioned the interests of pharmaceutical companies before. I just wanted to ask how intellectual property rights, and especially patent laws, factor into that whole debate. I know I haven't followed that entirely, but there's something like a Doha declaration that enables, like, the poorer countries, the WTO member states, to issue compulsory licenses, but that doesn't work in all instances, especially not if those countries don't have the facilities to actually manufacture these drugs. Can you go a little bit into that? So
it's a really important area, and actually the availability of generic products has allowed is one of the factors in a remarkable reduction in the price of all of the products. So antiretrovirals, when we were putting together PEPFAR, were about $1,500 to $2,500 per year per person. We're now down to $80, which is pretty breathtaking. And generic competition and manufacture actually had a lot to do with that. For us, intellectual property and for where we invest, has not yet been a huge issue because the vast majority of the countries we work in don't have intellectual property laws. And because most of the companies now, and it took a lot of advocacy and took a lot of public beating up to get them there, but most of the companies now don't enforce their patents even where they exist in low and low middle income countries. The tricky part is upper middle income countries. And that's where the complications are starting to arise. We don't actually support countries to buy a lot of, by the time you're an upper middle income country, we're mostly investing in civil society strengthening, key affected populations, human rights focused efforts rather than large procurements because the countries do those. But there are other groups that work on this issue, and there's a new UN commission on it. It's tough. I mean, there was a study published a couple months ago that showed that countries that issued compulsory licenses actually paid more for products than countries that didn't issue compulsory licenses. But the threat of the compulsory license probably led to the companies reducing their prices to a level that allowed for that. So it's a complex environment. We are not overly engaged in that because we're not a trade organization, we're not a technical organization. There are organizations that do, and we partner with them. Unitate is one, Medicines Patent Pool, which is actually a cool mechanism whereby countries give away. Most companies now most of them just give away their licenses to a generic manufacturer because they're not going to make any money of it off anyway. It is a problem for TB and malaria drugs. And we're a little more engaged, but we mostly partner with the groups that are heavily engaged in that. UNAIDS is very involved, UNDP. There is potentially another round of Doha. It's been blocked for a while. There are free trade agreements, which some people think are going backwards, but I'm not competent to talk about those. There is a body of literature. Médecins Sans Frontières is very involved. Oxfam's very involved. So there is a body of literature if you'd like to look at it. We're less directly engaged because we're really a financing mechanism, not a technical agency. We partner with the groups that do. There are real issues, but they're complicated. And like everything, dogma and simple answers probably isn't it. There's something in between. I was talking to the CEO of a big pharmaceutical company about intellectual property. He was like, and unfortunately, very few CEOs feel this way these days. There was a time. It's like, look, intellectual property doesn't give you the right to charge whatever you want to charge, you know. And it's the area under the curve. If you sell a product, if you sell 100 things for $1 or one thing for $100, you make the same amount of money, right? So there's an in-between between access and pricing, which unfortunately, because of shareholders and a lot of other stuff, we're moving in the, you know, some of the pharmaceutical companies today remind me of the railroad companies or the electrical companies, you know, that are just outrageous what's happening. But at the same time, you need some incentive to continue to invest in, say, producing a new TB drug or a new malaria drug. And if you don't have any, if there's no protection of any kind, we've actually created something as an innovation which we hope is kind of an in-between that could solve the problem. The reason for intellectual property is to have a market. It's basically have a long-term market to recover costs, which get grossly inflated, and we know they do. So we had this great idea, you know, pooled procurement works really well, right? It brings prices down. A great way to bring prices down. We now have innovators bidding generics because they know what their volume is. So as long as you can guarantee a volume, you can actually reduce your price. If you can't guarantee a volume, then you're kind of spot pricing. So we had the insight that if we pooled procurement and made it available, which we'd been doing, but we've been managing it, we could really reduce prices. So in the last 2 years, we reduced the price of bed nets for malaria by 40% in 2 years by just pooling the procurement and negotiating. But that's us doing it. What happens to a country when we're not there to do it for them anymore? So we challenged our procurement team to come up with a solution, and they came back with a simple, brilliant thing, which probably half of you in the room thought of. So we basically created a kayak.com, priceline.com for health commodities. It's called wambo.org. We just launched it, actually. And we believe this will be the pathway eventually to have open competition for medical products, not just the ones we deal with. We actually want to spin it off to a global public health good so that all health commodities can be on it as a global public health good with no skimming of money, so that you will have predictable markets, long-term markets, which would then allow for pricing that might overcome some of these issues. The other piece of it is also promotes innovation of companies. If you talk to companies in Africa or China, for that matter, no one will invest in quality assurance and getting quality products or even in the product themselves, because there's no market. The question every investor has is, how are you going to go and outcompete country by country, open up a market in 75 countries on your own? There's no access. This will give automatic access. All you have to do is have a quality product, and it will go on there, and you can price it wherever you want, and you can drive the price changes. So we think this will stimulate innovation in commodities. We think it will stimulate price reduction, and it's a simple technological solution. It's also a way that if you have a long enough term predictability, the smart companies will start pricing in a much different way, and then intellectual property, which was your protective mechanism, might be a little less necessary.
Well, what's the name of the portal?
It's called wambo.org, WAMBO.org. You would understand why. I was like, why the hell would we pick a name that no one understands? Or like, did you know what Yahoo meant? Did you know what Google meant? No. So you create a word that means nothing really, and turn it into something that has a meaning on its own. So it's in its early stages. We actually just launched it as massive effort. For now, it's just available to some of our what we call principal implementers, the people we fund. By the end of the year, we're going to let any country that wants to use it for HIV, TB, and malaria. And then our goal is within the next year to work with other global health organizations to create a governance mechanism and turn it into a global health good. You could see the VA and the National Health Services starting to use this. We'll get in a lot of trouble actually when it gets to that point, but it'll be fun. I think we're at your 6 o'clock, your It's your bird saying it's time for happy hour.
I think the cue to finish has come. Yeah, this is our Heidi song, and that means that TGIF is starting. So for the two of you in the room that don't know what that means, please have a beer. Thank you very much, Mark. It's been great listening to you.